It's so good to see so many faces that I know. So, as Dr. Adams was talking, I was removing slides so we can stay on, because you guys are crazy about getting done on time. I'm driving up to Helen tonight, so I'd like to enjoy it before it gets too dark. You excited? I am. Thanks to politics, I've put 2 kids through graduate school in changes in healthcare. And when you get home tonight and you turn on the news, you'll see what's going on in Venezuela. And that's what happens when healthcare's free, I guess. Let's have fun tonight, though, and talk about coding. We're going to talk a little bit about some things that I've covered before, but just to kind of get you excited about this a little bit more. So many of you I've worked in the past on E&M coding. I met with your staff today and we talked about the future changes to E&M coding and how that's all going and the quality payment program. But of all the systems that Medicare has implemented, this is the easiest one. It really, truly is an easy program. We'll talk a little bit about it tonight, some financial numbers, some tips, tricks, common HCC codes, and examples. Now you remember my fat running guy, right? My first 5K after I got diagnosed with diabetes. You got to start looking at patients like Dr. Adams was talking about as a patient, but also what the value of that patient is to our clinically integrated network. One of the ACOs that I work with who implements this program that I do effectively, some of their doctors took home $175,000 bonus payments a couple years ago. This is the future of healthcare. And it's only difficult if you make it difficult. The entire purpose of this entire model is just to forecast future expenditures. There's different programs. There's 5 separate ICD-10 coding models. We primarily are going to use the CMS model or HHS model. Medicaid in this state is going to roll out a model called the CDPS. So if you're a pediatrician or you're an obstetrician, a lot of the codes that you bill for don't necessarily have HCCs because Medicare doesn't treat those kind of patients. If you see people in the exchange plans, every program has an HCC value for something, and it's all just to project future expenditures. It's been around for over a decade, and if you're a doctor here today, your staff has probably come to you and complained about a company named Ciox. They request hundreds of medical records from you every month for the entire previous year. And that's because you see patients, and this is going to tie into what Dr. Kevin said, you see patients all the time and you bill United Healthcare, you're 99214 with 3 or 4 diagnosis codes, think you're on top of the world. They don't get paid based on what they pay you. They get paid on a cost report. The federal government reimburses them based on what Jeff does. So that one patient that Jeff had an increase in the risk adjustment factor, we can code from just about anywhere in that note. So these managed care companies hire people and pay them $30,000, $40,000 a year just to sit at their desk all day and go through your documentation and do what Jeff does, and then they'll report that to the federal government. United Healthcare, Managed Care, Medicare makes a lot of money. It'd be nice if they shifted some of that to you, but they don't. They keep it, and that's the business model that they're in. Who better is able to determine that your coding is terrible than United Healthcare? They know that because they've seen your documentation and coding because they have all the Medicare contracts now. So if you were a managed care company and we were trying to stick it to physicians and set up a new pay model to pay them, what would we do it on? The thing that they're the worst at, which is your ICD-10 coding. It's the perfect scam. If you've got a camera, this is what I'd tell you to take a picture of, the big 7. There are 7 diseases that you guys see every day, and that's all I want you to really start understanding. If you can understand these 7, your risk adjustment scores will go up astronomically. And it's not that you're faking or that you're lying. It's just that you're painting a Picasso of your patient instead of the current stick figure that you're sending into the insurance companies. If you want to live in that world, fine. But if you further on down the road, you're not going to be, we got to do what's best for the, I'm just saying, you're not going to survive. Just think of this. Morbid obesity leads to hypertension. Hypertension leads to heart disease and chronic kidney disease. Diabetes. Morbid obesity leads to diabetes, which there's codes for diabetes with hyperglycemia. A lot of your A1Cs are above 7. There's a lot of patients who have proliferative diabetic retinopathy that carries its own HCC. Diabetics have chronic kidney disease. My nephrologist is a client of mine because he coded me all wrong. He was going to lose money on me. And I was like, what are you, nuts? I'm not a 99203, first of all. I'm a 99205. And I'm not an N18.1. I'm an I12.9 N18.1, E1122. And I'm also bipolar. So why aren't you coding that? What are you, nuts? What are you doing? And he's like, you know how to code? We've been looking for a coder. He doesn't really talk like that, but I don't like him anymore because he's skinny. When I started going to him, he was fat. So he didn't get on my back that much. Now it's all like, he's keto man, CrossFit keto. Shut up. Just leave me alone. Do you have any fat doctors in your group that I could transfer care to? But you should know how to code morbid obesity, which is one of Jeff's examples. Hypertensive heart disease, I11. So here's what you need to write down. I would know if I were a doctor. I'd know I10, I11, I12, and I13. I'd know those codes. I'd know I50. In fact, if I were a doctor, I would just simply take this handout, because all the codes you ever need to know are right here. There's 2 handouts in front of you. I've been in this business since '92 through all the changes because I try to help you fix stuff. So this first page that looks like this, it tells you the codes for morbid obesity. It tells you the HCC that Jeff and all the CAAP people know. So my BMI is over 40, so I'm E6601. That number 22 is just which one of the buckets it's in. I'm going to explain that a little bit more, but what you need to look at is the risk adjustment value for that bucket is 0.262. Underneath that is hypertension. You see the number 1 code you pick every day is I10. It has no value. But hypertensive heart disease with heart failure is worth 0.310. Now Medicare has a denominator of $9,000. Commercial plans don't. So if this was a Medicare patient and you coded them as hypertension because of the default, when you go into your EMR and you type in hypertension, it gives you what we call in the coding world the default code, which is the first code. And the default code for hypertension is I10. If you don't expand on it and say, oh, they have hypertensive heart disease with heart failure, which would be I10, and then I've even helped you further by underneath that code I wrote, use the additional code for heart failure. Do you see that? And then that code's at the bottom. Even I50.9. So I'd know hypertension, heart failure. If you turn the page, you'll see chronic kidney disease. This year, N18.3 got a value, which a lot of you guys see. You weren't getting paid for N18.3. Diabetes is right underneath it. Those aren't all the diabetes codes, they're just the common ones. But look on top of diabetes, because we're going to talk about renal failure today. I'm going to show you a common example that costs most ACOs and companies that are under a risk plan to lose a lot of money, and that's Z99.2, dependency on renal dialysis. That's on the list up here. Diabetes, chronic kidney disease. There's your COPD. You turn the page. I don't know why it's doing this, but that's fine. Here we go. There's some cardiovascular diseases, AFibs, AFlutters. Look at your psych codes. I really want you to look at psych. Right now, when you guys see a patient who's on an antidepressant, I said this morning, I'm sounding like, I'm not going to say it. F32.9 has no value. That's unspecified depression. right? But if you look at F32.0, 1, 2, there's other codes that are in your EMR that talk about mild, in remission, 1 episode. Be specific. Look, if I come to your practice and I've got bipolar, look at that. I'm 0.353. A fat bipolar diabetic with kidney disease? You can close the office early today. You can finally get that S series that you've been wanting. You've had your eye on for a long time. And as we move further in coding, this morning I talked to your staff about E&M coding going from 1 reimbursement for level 2, 3, and 4. Medicare's projecting that. So you'll have 1 payment for levels 2, 3, and 4. You guys, it'll be about $103. You'll make huge increases in revenue. And if you spend 34 minutes with that patient, you can make as much money on a patient in the future as you'd get paid for a 99215 right now. So there's a lot of opportunities coming forward where you'll have more time to spend with your patients and the providers will be able to get this information. So don't forget your psychiatric codes that are up there, your COPD, the big 7. These are the ones I want you to learn. It basically works this way. You pick a code, it goes to Medicare, it goes to Blue Cross, Cigna. They convert it into a bucket, stable diabetes, which is the default code for diabetes, only has a value of about 0.106, and it's in bucket 19. No money. Even for Medicare, that's $900 a year. But if you go to page 2 of that handout, a hyperglycemic patient, as Jeff and Dr. Kevin showed you, is 0.306. It's worth 3 times the value. But you have to look for that code. And your EMRs are going to get better. I was at University of South Florida. They're a big client of mine, and they're on Epic. And you go into their EMR, and you type in diabetes space HCC, and it populates every HCC code. If you're on Athena, it'll populate codes that you haven't used in the last 12 months. Artificial intelligence will help you with this. Do not panic. The typical score for a Southerner is about 0.4, and Medicare sets the plan up so that the average patient is worth about 1.0. But every day you're billing this as 214 thinking you're on top of the world. I'm getting my 214s. Let them come and audit me, and what you're really doing is shooting yourself in the foot because you're picking codes that have no risk adjustment value. Because this guy is also probably fat. Right? He's probably morbidly obese. Can't you wait until they legalize marijuana in this town, in this state? They're talking about building a marijuana field in Augusta. Good luck with that. That's where I live. Because the governor just approved, dispensing of it. But once that comes, you're going to see those codes. Look in your handout at dependency. It's on page 3 of 5. Get excited about coding. You want to talk to your congressman. Cannabis dependency is 0.368. 0.368. You don't know this, but that's more than breast cancer. That's more than prostate cancer. So as soon as they legalize weed, all y'all are going to get another bump up in your money. The goal we want to try to get is 1.0 to 2.0, and what CAAP does through their clinically integrated network is this. When I have my EKG done, you guys look at it and you know what all the squiggles mean. I'm impressed. This is our EKG. I look at this ICD-10 productivity report. The arrows are the only ones that have an HCC value. So CAAP looks at this on you. And they go, oh, acute kidney failure. What caused it? Respiratory failure. Well, that probably happened in the hospital. Where's the sepsis or the severe sepsis? Oh, N18.6, end-stage renal disease. What caused it? Where's the E1122, the diabetes that caused it? Where's the I12.9, the hypertension that caused it? Where's the Z99.2, the renal dependency on renal dialysis? You see? I25.10, coronary artery disease. Everybody's got it. But you don't get any credit for it unless they have angina. So we look at this kind of stuff, and they'll come out to your office and go, wow, I'm looking at your quality scores, and a lot of your diabetics have A1Cs above 7, but your number 1 code for diabetes is controlled. So they help you, and then you in turn kind of coordinate and say, oh, all right, I see now what Steve's talking about and what Jessica and everyone out there at CAAP is talking about. my Notre Dame guy. I've shown him before. You got to look at people and go, well, is this guy, like my wife is probably less than 1.0. I got to be pushing 5, 6 on the risk adjustment factor scale. It's funny now until one of you are taking care of me in the hospital. But the equation for Medicare is you just add up the total risk adjustment score and you multiply it by 9,000. Commercial plans are going to have a lower risk adjustment denominator. Here's the impact though. Watch carefully at what's going to happen to you someday. All right? This is one of the largest ACOs in the Southeast. They were not risk. They saved the government $9 million, but still got no love back from the government because for the first time ever, it says that their risk factor number dropped by 2.2% for the first time in effing history. That's not what it said. It's just, it was the name of the company. It's just funny to me because I have a dirty mind. But if that risk adjustment factor wouldn't have dropped and would have just stayed at what it was last year, they would have saved $22 million, met their MSSP, and all got big money. But doctors, you know, I'm not going to hit one more damn button on this computer, Steve. I'm just not going to do it. I'm just not going to do it. I'm done. Well, fine. I don't want to drive to Helen tonight. I'd much rather be at home with my wife. You should have seen my little chihuahua look at me this morning when I left home. She's just like, can you please not leave me? But we do what we got to do. This is the field that you chose, and this is the way we get paid. Look at what they also found. If they had retained one healthy patient, one more annual well visit per patient. If they had one fewer hospitalization per 342 patients. Now, my firm, we track this in ACOs. And we look at this data and we go to doctors and we say, hey, listen, here's your admissions per thousands. We follow that and track it so you know if you're a doctor. And then similar to what Jeff and Dr. Kevin put together, you know, a typical patient, you look at the note, we see this all the time. Medicare requires you to code this, as do other plans, for once in a 12-month period, January to December. So we look at every note that happened. Every note was a face-to-face visit with a provider, doctor, nurse practitioner, PA, can't be an MA or an RN. But we see all this stuff, but you're just thinking, I'm only going to code the stuff that I'm treating. That's your mentality, because that's what you've been told. And you've been told that by your coding staff, and they were told by the people who trained them. And I can guarantee you that there's not one coder in this room who, my wife teaches kindergarten. And on what do you want to be when you grow up day, there is not one kid in her kindergarten class that says, when I grow up, I want to be a coder. People are coders because somebody in your office died, or you fired them because they were stealing money, or your AR went out of control. And you're just like, oh, well, this ain't hard. I'll just put Susie in that spot. That's what happened to me. I was the check-in girl at the eye clinic. And when Arletta died, I became the checkout boy. So they don't understand coding very well. And that's why CAAP tries to help you and works with your staff. And the key for you to remember is you're not treating a lot of these problems. You're not treating that amputation. You're validating that that patient has that. That's what you are. You're doctors. If you see me this afternoon for a sore throat, your medical assistant is going to take a list of medicines that I take, yes? And if I'm on metformin, 500 milligrams ER twice a day, and I tell you that I have diabetes, you can validate without an A1C that I have diabetes, yes? If I'm on Depakote because I tell you I'm freaking nuts and I'm not in a manic state right now, you can assume that if I tell you I'm bipolar, that you can write that down and you can validate that diagnosis. You understand? That's what you're doing, validating. And just like Jeff's, we see an increase. Now, these would be things that were documented in the record that could be coded, and if you were rich, you'd hire somebody like me. And I'd just sit in your office all day and code for you. Now, if you were making an extra $16,000 per patient, you'd pay that money. That's why when you were residents at the hospital, they had people doing what? They had case mix managers just walking around the hospital doing what? Checking on your documentation. Because they get paid based on that. And that's the model we want you to go to. So some practices that I work with, we take the big 7 and the doctor just sits down and makes a list and says to their medical assistants, hey, listen, if a patient, here's the most common drugs for heart failure. Here's the most common drugs for bipolar, for depression. You can Google that stuff and make a list. Some tips. There's little diabetes. This is my weakness. I love me some little diabetes. Remember when I told you can code anything? You're going to go back to the office and the coder's going to tell you, oh, he's wrong. Really? I'm wrong. Okay. That's because they don't read the book. I just read an article yesterday that 1/4 of Americans do not read every year anything. But if they go to section 4 of their ICD-10 book, it tells us to code all pre-existing conditions. And that rule has been around since before time. You list everything. Yes, we are telling you to validate all diagnosis codes. Because I'm crazy. I might not take my bronchitis medicine. I have diabetes, so I can't get certain medications. When I'm in pain, I can't take ibuprofen. And I'm really in need of medical marijuana. And I'm telling you, I'm trying as my hardest. And I was so bad, I was up in New York a couple weeks ago and working with some doctors up there that are doing these Suboxone clinics. And we're joking around about weed, because I just like to joke. And they were like, dude, you're 10 miles from Canada. It's legal. And I said, damn it, I forgot my passport. That will not be a problem next year. It's in my wallet right now, just in case. Codes can be from anywhere. If you hired somebody in your office to code, like what Jeff and all the CAAP people do, they can pull diagnoses from anywhere. We don't try to go with the medical history so much, but we like to code from the history, the physical exam, the impression, assessment, and plan. So when Dr. Kevin was showing you the amputation that showed up in the physical exam, that's codable. We can code from a lot of places. We don't like to code from problem lists because you might write down medical history prostate cancer, and I want to show you in just a little bit the 3 big errors that doctors make. Because remember, United Healthcare Managed Care, Blue Cross Managed Care, all those Medicare Advantage organizations get paid this way. If you make a mistake here with risk coding, it takes money away from everybody in the group, not just one person. So if you code that somebody has metastatic cancer, which is the highest risk adjustment value, it's like 2 point something, and they find that one error, they take 2 points away from the entire patients in your clinically integrated network. So you cannot make mistakes with this. We don't code probable suspects, consistent with. But let me show you the 3 mistakes people make. We talked about stroke earlier. You can only code a stroke during the acute phase of the stroke. Once the patient's discharged from the hospital, you can't code the stroke anymore. It's a history of stroke unless they have a neurological deficit. So in your office, your staff probably doesn't want you billing 99215s all day. I tell your staff, if you see an I-63.9 come through the office, that's a problem. Go back to the doctor. I-63.9 has a value, and it's high, and it's only one time. And like Dr. Kevin said, you may get paid for it in this cycle, but the residual effects, even if they have any kind of neurological defects afterwards, the following year, we get a risk adjustment value with that also. We just don't get a risk adjustment associated once they leave the office. So 2 years from their original stroke, if they're fine, we don't get any more money for them. Cancer's another one. We only get to code cancer if the patient still has the cancer or is getting treatment, active adjunct therapy for the treatment. So they've had prostate cancer, or they're on Lupron, or they've had breast cancer, or on medicine still for that, even though they've had a mastectomy, we can still code that as cancer. But once the cancer's gone, we can't code it anymore. No longer can code it. So those are the kind of, and then there's one more, and that's a heart attack. So once you've had a heart attack, we can only code that for 4 weeks. After that, it's just ischemic heart disease. So after 4 weeks, we're up. So those are the ones to watch out for. So there's the big 7, which should be easy. High fat obesity leads to, just turn on the news tonight. Just watch a commercial. Oh, Sam Rick. They've taken all my favorite songs and turned them into drug songs. But every commercial that comes on TV is part of the Big Seven. That's what we're dealing with in America. John Singleton, the director, long-standing, outstanding history of hypertension, led to a stroke. It's everything. You got it? Now get to know the tables. How many do I really want you, and be careful. This is kind of a funny sign. Don't go to Kansas City. Read the sign, doctors. It's funny, laugh. I've got a long drive ahead of me tonight. Don't be a sourpuss. You know what's bad about this is somebody typed it up, somebody obviously approved it, and then somebody actually hung that up. It went through at least 3 people and nobody noticed except the short fat guy at the front of the room tonight. But get to know your tables. When we look at diseases as non-clinical people, the number 1 disease in the Medicare population is hypertension. What are the codes for hypertension? What would you go to if you didn't remember? You don't have to think, they're right here. I-10, I-11, I-12, and I-13. Has anybody in this room seen a patient this week who had hypertensive heart disease with heart failure? Yeah. And maybe you coded it, maybe you didn't. If you didn't code it, think about how much that cost you. That would be like if I was doing this meeting back in '92 when E&M codes came out and you were billing all 99212s, and the first time you heard, that's a 214? I could make an extra $70 on that visit, and you know how excited you got? This is the same thing. So there's 71,932 diagnosis codes. 10,000 of them have some kind of risk adjustment assigned to them. And those 10,000 are put into 84 buckets. So look at this handout. What bucket is morbid obesity in? Bucket 22. Do you see that? That's your HCC bucket. It's on the first page. Your staff can pick Z68 codes, the one for BMI. There's only 2 things that your staff can code without you physically writing in a note. 2 things. They can code the BMI without your permission, and they can code the stage of a pressure ulcer without your permission. So even if you did nothing more but tell your coding people, if the BMI on the EMR is above 40, pick that code, your risk adjustment factor would go up by 0.262. 0.262 tomorrow. If you refilled somebody's depression medicine and just didn't use F32.9, your risk adjustment factor would go up. This handout is super cool. This is for the super cool doctors who want to know everything. This is all 84 buckets and every diagnosis code that's in every bucket. This other handout. So if you ever wanted to know if something was in a bucket and you don't have a list, first of all, call CAAP because they can tell you because we have software programs. Or you can just hold this in your hand. Look at bucket 18 on this list. Bucket 18 is your diabetes. Diabetes with chronic complications. See how it even has 0.307? That's part of the Big Seven. So you have everything you'd ever need right here in both handouts. Here's why a lot of people fail. If you're an internist or a family practice doctor, is anybody here seeing a patient who's on dialysis? Sure you do, right? And they're usually out in your lobby in a wheelchair. They're morbidly obese. They're missing 1 or 2 legs or a foot. And you don't know how to code that. Well, first of all, we go to hypertensive. We go to page 1 where it says hypertension, chronic kidney disease. I-12.0. Do you see that? Hypertension, chronic kidney disease with stage 5 CKD or ESRD. Do you see that? On this page here. This one here. It's on the first page, I-12.0. Underneath it, it says code what? The stage of chronic kidney disease. So you go to the second page, and that's your N18.6, right? Then under N18.6, it says Z99.2, dependency on renal dialysis, right? You'd want to code that also, yeah? And then if this patient's also diabetic, which they probably will be, you can also pick the E1122 for diabetes with chronic kidney disease. Then you'd be able to flip through here go to the page 3 of 5 and pick your required absence code. And you see how this is all adding up. It's not just 214s anymore. So here's the problem with ESRD. You think you're doing a great job, you code end-stage renal disease, but you don't code what caused it, the hypertension or diabetes. So all we get is 0.284. That's about $2,000 a year. Now, if you coded it with the diabetes that caused it, now we're up to 0.591 or $5,319. But what most primary care physicians don't do is code the Z99.2, which is the dependency on renal dialysis. And when we use that code, that's in bucket 134, it's worth 0.474. And what it tells people like me and Jeff and the CAAP people is if you use this 134, you can't use any of these other buckets. You can't use anything from 130. So it basically saying that you're on renal dialysis eliminates your ability to bill the end-stage renal disease, but that still increases us up to $7,000 a year. So when we look at that one ACO that lost all that money, usually clinically integrated networks or ACOs lose money the quickest by not coding their end-stage renal disease patients correctly. One patient. And you see them all the time. And if those people are attributed to us, and you just remember to use the Z99.2 and remember to code for the cause of the diabetes. If they have hypertension and diabetes, you can use both causal agents along with the ESRD and the Z99.2, along with morbid obesity, the big 7. Just remember those big 7. Yes, still. We talked about shortness of breath, that's COPD. Now, nicotine dependency doesn't have an HCC. Smoker's cough does. Anxiety, no value, but depressed mood does. And these are the kind of things that when you have trainers come out to your office, they'll look at your coding profiles and they'll help you. Some doctors put these in their drop-down boxes. I have one doctor in Augusta who loves Georgia football, and he took one of those football things that flips up, and he wears it around his wrist. But you know what? His HCC scores are highest in the county because he doesn't miss anything. Some doctors take pictures of these with their iPhone. So while they're in there, you have picture. Use my iPhone for everything. I take pictures of everything. And then I have it right at my fingertips. You only have to document these 1 time a year. We talked about morbid obesity. Look at the values. Hold this up and then go to this big fancy handout. Let me show you the sad state of affairs. Go to this one. Look at bucket 8, metastatic lung and acute leukemia. Do you see that? Bucket 8, yes? You've seen patients this week who have metastatic cancer. You're not treating it, but you can validate it. When you validate the metastatic cancer, the primary cancer is less important. We don't care because they have to drop that one. Go down to bucket 12, breast, prostate. You see that? That value is 0.153. That's less than morbid obesity. These are the things that as you progress in your coding knowledge as a doctor, you'll want this. You'll want to know what to code. One of the things that Jeff asked me about today is if you look at bucket 18, diabetes with chronic complications. If you have a patient with diabetes and proliferative diabetic retinopathy, which is bucket 122, go to bucket 122. You get paid 2 HCCs for that, 08 and 108. Same thing with proliferative vascular disease. That's a combination code, E11.51. Jeff asked me to look into this. You get paid for both. You'll learn more. Like everybody in this room knows what pays more, a 215 or a 214. You all know that. You'll know which HCCs have the highest value. There's your hypertension. There's your heart failure. It's okay if you don't know the type of heart failure. I-50.9 is an unspecified code, but you can still use it. Chronic kidney disease. There's your dialysis. Don't count on the nephrologist for coding this. They ain't good. They make their money from their dialysis centers. The last thing they're thinking about is coding. I know, because they're clients of mine. Everyone in that, not everyone. This is just a short list of diabetes. But because the proliferative diabetic retinopathy has its own value, that's why a lot of larger groups, like I work with the Rome Clinic and the Long Street Clinic, going up there Thursday and Friday to teach this. They have physician on staff at the Long Street Clinic that just goes around working with the doctors there, teaching them this. This is so important that they've brought in primary care physicians just to do pre-ops on patients who are coming to their organization from outside. So let's say you're referred in to get a total hip arthroplasty, and that patient's going to get allocated to us. We want a physician to do your physical so that we can capture all these codes prior to doing your surgery. That's how important this is. It's crazy. COPD's unspecified, Crohn's, ulcerative colitis, all these that you examine here, schizophrenias, manics, bipolars, depression. Try to use the F32O, 1, 2, 3, 4, 5. Stay away from F32.9, unspecified. It has no value. Now, go back and look. So F32, here's what that other sheet helps you. That's in bucket 59. So if I went to this big handout, because you're shy, you don't want to bother Jessica's people, Janet doesn't want to be bothered. So you go over here and you just turn to bucket 59, and it tells you all the codes. And if I look in bucket 59 on the second page, is F32.9 listed? No. F32.0 to F32.8 is listed. This is the simplest thing that I've ever had to train anybody on. This is better than patient-centered medical home, CPC plus, E&M coding. It's really simple. There's your acquired absence. I was asked a question about drug dependence today. So in the ICD-10 manual, it tells me that if you see a patient who's on an opioid that's prescribed by another physician, you can't bill use, abuse, or dependency codes. You just use Z91.891, which has no HCC value. So it tells us that we can only use this code if it's prescribed. If it's not prescribed, then you can use the F codes. Lupus, RA has a value. You see people you see these folks all day. If I was in primary care, I'd probably try to do this during my annual well visit. You do your GO439 with your 99214, and I would just tag all these additional codes to my 99214 once a year. Nobody's here in OB. This is funny. Bob has 36 candy bars. He ate 29. What does he have now? He has diabetes. All my slides tonight are fat jokes, so just kind of bear with me. Just to drive home the fact that the cause of all this is Little Debbie snack cakes. Twinkies and ding-dongs. This is a client where we actually see that they went through and they used the same EMR, and they took somebody like Jeff, and Jeff went in to their database and wrote HCC next to every code that has an HCC value. So now all this group doctors has to do is when they see it over here, they just pull it over into their active problem list. So the person had morbid obesity, wasn't coded, seizures weren't coded, and we didn't get the BMI coded. This patient had hypertensive chronic kidney disease. Do you see how I drew the arrows? Wasn't coded. They just coded the default hypertension. Now, we wouldn't have gotten a lot of money off this. It's I-12.9, N-18.3. It would have been only worth 0.68, but that's still more than you're getting right now. And if the AFib's still present, we would have got that. But again, just didn't code it. Diabetes, sleep apnea, hypoxia. Have to remember to code the stage of chronic kidney. Oh, remember, chronic kidney disease is not always, I'm not a doctor, I'm not a nurse. I was a medic in the Army. What am I telling you people? Motrin. It was peacetime. It was the Cold War. I can give you Motrin. Help you if you got a blister on your foot. But from my coding knowledge, I can tell you that chronic kidney disease is usually linked to either one or both hypertension or diabetes. And I want you to remember that. Also didn't code the depression. Now it's sitting there in the note. And the easy thing to do would be to just have somebody. So some larger institutions are starting to do a couple things. If you're in a big group, have somebody look at your notes the day before and send you a message through the EMR that says, hey, listen, we saw this person in the past. I'm going through their notes. Here's some ideas of things that you can code today. Other doctors take this list. They call their EMR provider, and they say, hey, put these in drop-down boxes. So when I hit hypertension, I get more than just one option for hypertension. Other people train their staff. The Longstreet Clinic works with their MAs. And their MAs know how to code. And their MAs point these things out to their doctors because they're under a lot of risk adjustment contracts and are doing quite well under them. They've embraced this, just like you guys have. Here's your diabetes uncontrolled. A1C was 9.5. Now, I could, in trying to save time, is there a specific diagnosis code for uncontrolled diabetes or hyperglycemia? It's on page 2 of your handout under the heading Diabetes. And it's E11 at the bottom. E11 starts with a 6, 6.5, E11, 6.5. If you don't do anything tonight, when you leave here at the end of this talk, I'm going to have you take those 4 pages and I'm going to have you circle 6 or 7 codes that'll change your life forever, like Tony Robbins. They're simple. Here's a patient with type 2 diabetes, hyperglycemia, didn't code the hypertensive heart disease with heart failure. Go to page 1, please. Can hypertension lead to heart failure and chronic kidney disease? Yeah, what's the code for hypertensive heart disease with heart failure? I11 what? Heart failure. I11 O maybe, and then underneath it says don't forget to code the heart failure, which is at the bottom of the page, which would be I50.9. It's not hard to do. There's so many examples. Here's another one where hospital discharge follow-up, post-herpetic neuralgia, ESRD on dialysis, but didn't code the hypertensive chronic kidney disease, stage 6, just missed that. Got the Z99.2, but the scenarios that we went over tonight, I'll summarize in just a minute, okay? The most common ones. No money for anxiety, but depressed mood, swing, those codes have value. Depression's tricky. See that F32.9 has no value. It has no bucket. But F32O, 1, 2, 3, 4, 5, 8, 1, 8, 9, those all have buckets. So it could be that CAAP calls you and says, you're using F32.9 a lot. Listen, if you left here today and just didn't use that code anymore, you'd see an increase. If you left here today and just told your staff, code some Z68s, you'd make an increase. If you left here today and just said, by God, if the A1C is above 7, I'm going to use E1165, it would change your coding, right? If you left here today and just said, when I see a patient on renal dialysis, I'm going to code the hypertension, the chronic kidney disease, and the dialysis, or the diabetes that led to the chronic kidney disease and the dialysis. It would change you, change your scores. Typical patient, 99214 all day. GO439, annual physical. Billed a 99214 with the type 2 diabetes, with the neuropathy. The good thing about that number 2 is it says his A1C was 9, repeated it was 7.3. You only get credit for one code in a bucket. You only get one bucket a year. So in other words, if I started in May and I was E11.9 because my diabetes was good, but then in May it shot up to 7.3. I'm in a different bucket. You only get one bucket per diabetes. They give you the highest bucket. Unless you also have peripheral vascular disease with diabetes, an ulcer with diabetes, or proliferative diabetic retinopathy. I don't expect you to know those things. That's what CAAP is for. That's what Jeff is for. They know that kind of stuff. What you need to know is the stuff that we've talked, the big 7. Change you forever. Coronary artery disease. If they've got angina, code it, because we can get an extra HCC for that. But when you go into your system and you type in coronary artery disease, it's going to give you, again, what's called in the coding world the default code, which is the code that has no value. And that's just the way SNOMED is built. It wasn't intentional, but it's just the way it works. See that E11.9 is bucket 19? If you code that, that's worth nothing. It's a very low HCC value. So take this 4-page handout again. Let me just show you some things that'll change you just so quick. The 4-page one. On page 1, and I think that the CAAP people would appreciate me telling you this. Oh man, we're doing really good. I shouldn't have taken out. I had 4 or 5 really good slides. Maybe I'll show them those too. Z68 codes at the top. Do you see them? Morbid obesity. Do you see those on page 1? Just start coding their morbid obesity. Just get the BMI. We need that for your quality, for your HEDIS anyway. For hypertension, think if a person has hypertension and chronic kidney disease or hypertension and heart disease, there's extra codes for that. There's I-10, I-11, I-12. I don't even think, you don't have to be a magician, but I-13, you see people who have hypertensive heart disease with chronic kidney disease, that's I-13. That's going to require 3 codes. So baby steps, if you just remember I-11, more commonly in your office, you're probably going to see hypertension, chronic kidney disease, which is I-12. Heart failure, I-50 at the bottom of that page. You don't need to know if it's systolic, diastolic, acute on chronic, just I-50.9. Turn the page. Your N18, see that N18, those codes up there? See those? If you've got an ink pen, N18 codes are usually caused by hypertension, which is I-12, or diabetes, which is E11.22. Just write those 2 codes in that box. Now, if the patient doesn't have either one of those, just pick your N18 code. And underneath it, if they're on dialysis, remember to pick the Z99.2. That's all. Diabetes. Again, just watch your E1122s, your E1165s for the A1Cs that are high. Hey, if you see a patient 1 time a year and their A1Cs above 7, that you're only going to get credit for that one all year. They give you the highest bucket. COPD you see every year, every day. J44.9, that's a great one. Page 3 of 5. Remember we talked about everybody's bipolar, everybody's depressed. Look at that mood disorder. I told you about F39. Do you see that? Alcohol dependency, cannabis dependency, absence of a foot. That page 4 of 5 is just a bunch of pediatric stuff, just in case I do a talk with pediatric. They always want to feel involved. So I put some of their codes on there. At the bottom are some musculoskeletal, lupus, Crohn's, rheumatoid arthritis. And then the last page, 5 of 5, just to explain this page to you, you don't need to know this. This is all computer programmed, but if you put your finger on the left-hand side where it says 18, hierarchical condition category 18 is diabetes with chronic complications. And then next to it, it has the number 19. It's not on the screen, it's in your handout. That just tells people like Jeff and CAAP that if you bill an 18, you have to, and a 19 in the same year, you drop the 19. They pay you the one that has the highest reimbursement. So this is the list that tells us what does and doesn't count. So when Jeff is counting up your score, if you have questions, this is the list that he goes off of. This is kind of funny to me. You don't have diabetes, you won't laugh at this. Publix has free metformin. And you find out about that when you're accidentally looking in the Hostess Donut section. I don't know why I was there. I was just there. If you're a doctor, I just want to assure you, I talk a lot about eating things I shouldn't eat, but I just take an extra metformin and everything's fine. That's what my dad said to do. It's what he's done. All right, the big 7 again. Now, do they make sense? That's all we want you to do. I mean, yeah, you could get deep into this, but you know what you sell in your office every day as a doctor? You sell widgets. You sell 5 or 6 widgets. You sell 203s, 204s, 213s, 214s. You sell biopsies, destructions of lesions. That's all you do. This is the same thing. You're just selling those things and being more specific about what it is you're doing. If we do it right, big payoff. But we just don't have the people to come to your office and code everything. So I think that's why Dr. Kevin was talking about, when CAAP reaches out, let your staff know things like, no, we're not committing fraud or abuse, we're validating diagnosis codes, and this is important for you to know. We talked about the risk adjustment factor, 84 different buckets. Some buckets, if you look at this big handout, some buckets have dozens and dozens of codes in them. That's why every year, instead of changing 10,000 risk adjustment scores on 10,000 codes, they can just change the risk adjustment score on 84 buckets. It's real simple. Dr. Kevin talked about it's so hard saying Kevin Adams. When I was in high school, I was in a Black Sabbath cover band with Kevin Adams. We played Iron Man. It was so rad. We were so good. Facebook came out, and I called him through Facebook. I got in touch with him. And I was like, remember when we used to do drugs and play Black Sabbath? And he's like, I'm a youth minister now. And I was like, shit. Kevin, you just ruined everything from high school. It was so fun. When I say drugs, I'm talking about Bayer aspirins and Tylenol, of course. Financial impact. We talked about some tips and tricks. Let your staff know. This isn't fraud. This isn't abuse. This is section 4 of the ICD-10 manual. Open it. It tells you right there we're validating diagnosis codes. We have a second. Let me just show you what I did for one group. If I can find it. I hope it never works out. Under the cost component for Medicare, they're analyzing the cost associated with total knee arthroplasties. I didn't go over that with you because you're a clinically integrated network. But because of that, I have a group of orthopedic surgeons that I work with down in Crisp Regional Hospital, down in Cordele, Georgia. And their doctors were basically like most orthopedic surgeons. No, I'm not going to do that. So what we did was, we had to get their staff involved. Now I know this looks like a bit much, but this was a new patient intake sheet, and we just elicited questions from the patient. If you did nothing else but said to your staff, ask your patients these questions. Do you see a pulmonologist? You're not going to a pulmonologist if you ain't got a pulmonary problem. Do you see a cardiologist? Do you see a psychiatrist? Do you see an orthopedic doctor? Do you see an endocrinologist? That can at least elicit questions like, oh, you go to an orthopedic doctor, you have rheumatoid arthritis? Oh, you go to a psychiatrist? Now, you're going to see this patient 3 or 4 times over the course of a year sometimes. In a bigger group, you'd have time to request medical records from those folks to incorporate these diagnoses into your record maybe the next time. So we just kind of came up with this questionnaire to see if the patient, and at the end of the day, that's kind of where they went. They just came up with a list of questions, and their medical assistants now ask those questions to their patients. Do you see a cardiologist? Do you see a pulmonologist? Do you see a psychiatrist? And then because Medicare has calculated what the average cost should be for a total knee replacement. And the only way we can offset if we're above that cost is by making sure that our risk adjustment score is above 1.0. You got it? So there's all kinds of little things that you can do in your office. CAAP can help you with those kind of questions. What's the best way for me to implement this? And then my favorite slide. Listen, your best patients are bipolar patients. We're so fun. We're the ones who bring cookies. Look, if you have a patient who brings donuts to your office on an appointment, they're bipolar. I swear to God. If your patient brings, I don't like the way I'm mostly manic, but I don't like my psychiatrist office, so I'm constantly bringing her stuff for her office, which she's not legally supposed to take, but she loves me. Because I like bring her pictures and stuff for the wall, because she had some like Southwestern motif in there that was just, I cannot do this with you. We're going to fix this place up a little bit. So we're really good patients. And we have high risk adjustment values as well. Questions about risk adjustment. Can you do it? Yes. How many do we want you to start with? 7. What's the start with every one of them? What leads to all the problems? Morbid obesity, little Debbie's. I'm under the complete conspiracy theory. I'm not an Alex Jones guy, but I am convinced that aliens are fattening us up for when they take over the world. Because there is no health. I've got to go to Helen tonight. There won't be any fast food healthy places between here and Helen. Unless I go to Hardee's and get a carb-free hamburger or something. So they're just trying to get us fat so when they take over the world, we'll last on the long trip to whatever planet they're taking us to work their minds. Laugh now. Anything you want to talk about? We got done early. Any questions for Janet, Jessica?
Can you remind us what plans risk adjustment scores are based on?
I'm really sorry. I can't hear you really well.
I think I heard. Yeah, I think you asked what plans risk adjustments really kind of count.
Perfect.
Yeah, I would say Medicare is doing it with MIPS already. With CAAP, it would be Humana Medicare Advantage, all the MA plans that you may participate with, our commercial contracts that would calculate this would be Blue Cross Blue Shield in the EPHC program, and then most of the 2019, most of the managed Medicaid contracts would as well.
I would tell you this. Working as a guy who works with other CINs and ACOs, do it for everybody. Because what's going to happen is in 2 or 3 years, Blue Cross Blue Shield is going to come knocking on your door wanting to contract with you. And the data they're going to bring to you for your per member per month is going to be based on your current cost through your ICD-10 coding.
We already have that.
Yes. So you got to really do it for everybody. Now, some of your commercial patients aren't going to have all those comorbid conditions, but I would kind of go into the mindset, I would do it for everybody that I see.
Yeah, I would even say that even though we don't have an ACO inside of CAAP, your traditional Medicare patients not only count towards MIPS or your future payments there, but if they converted to a Medicare Advantage, you don't want them to take 1.5 years, 2 years before they catch up to the complexity that they truly are.
I'll leave this slide up here if you want to take a picture of it on your way out. If you have any questions, you can contact any of the CAAP people. The coders can help you out, better understand it. All the codes are here. This is everything we know on paper, and that's all I got.
Thank you, Steve.
No, thank you guys.